Hello friends, today we are operating on a 45 years old lady who has been suffering from left wrist pain for past 6 months due to chronic recurrent tenosynovitis. Surgical release is the definitive management for this condition when conservative measures fails. The objective of this video is to walk you through the precise steps of releasing the first extensor compartment safely and effectively. The site has been prepped and draped. We are performing this under local anesthesia without a tourniquet, utilizing adrenaline for hemostasis. First, we palpate and mark the radial styloid process. Our incision is placed slightly oblique, about 2 cm distal to styloid, following the skin crease, to ensure the cosmetic scar. We inject local anesthetic with adrenaline along the incision site. We make a very gentle shallow skin incision. It is critical to immediately switch to blunt dissection in longitudinal direction to identify and protect the superficial radial knob. Once the knob is safely identified, we gently retract it out of the surgical field. Immediately below, we visualize the thickened tendon sheath of first extensor compartment. We initiate the release with scalpel and then use a tenotomy scissor to divide the sheath longitudinally. We extend our dissection distally to ensure full release and then proceed proximally. In chronic case like this one, you can clearly see the thickened tendon sheath, and to prevent the recurrence, we carefully excise a small strips of thickened retinaculum. After the release, you should be able to sublux the tendon easily out of the incision site. I prefer to gently slide a dissecting tool underneath the tendon, moving up and down to break any remaining adhesions and definitely confirms a complete release. Always look out for a separate subcompartment for extensor pollicis brevis tendon, which is very common cause of surgical failure if missed. And at the end of the procedure, final check ensures that the superficial radial knob is completely intact and protected, and both abductor pollicis longus and extensor pollicis brevis tendon sublux smoothly out without restriction. After a thorough saline wash, we proceed to skin closure. I prefer using horizontal mattress suture here for superior wound edge approximation. Again, be incredibly mindful of the superficial radial knob position while passing your suture needle. Finally, we apply sterile compression dressing and the work is done. Finally, we apply sterile compression dressing and our work is done. Thank you for watching this demonstration. If you found this helpful, please like, share and subscribe. See you in next surgical video.